Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Hi, good evening, and welcome to another episode of Oncology Radio. My name is Dr. Raveen Garg. I'm a hematologist-oncologist with Maryland Oncology Hematology in the Annapolis Division. I'm also an assistant professor of oncology at Johns Hopkins Hospital. Today, we're going to be talking about various treatments in lung cancer. In particular, we're going to be focusing on immunotherapy. My guest today is Dr. Patrick Forde, so I'd like to welcome him to the show, and he was very gracious to come. Dr. Forde, I just want to give a brief introduction, then I would like him to tell us more about himself. But Dr. Forde is already at a young age an associate professor of oncology at Johns Hopkins Hospital, and he's won a lot of honors along the way. He's actually the director of the thoracic oncology clinical research program at Johns Hopkins Hospital, and he's had some really groundbreaking publications in the field of lung cancer. So very excited for Patrick to join us. So Patrick, I was hoping, just to tell the audience about yourself, your upbringing, what led you to medicine, to oncology, really kind of go back in time a little bit before we start talking more specifically about lung cancer. So I'd like to just hear about your background, if you could, please.
Sure. Thanks, Raveen, and thank you for inviting me to have this discussion this evening. So I came to the US a kind of unusual pathway. I grew up in Ireland and did most of my medical training there, medical school in Dublin, and then both internal medicine and oncology training there as well. So I came here with my wife, who's also a physician, back in 2011, and it was mainly for further training in terms of a fellowship at Johns Hopkins, which I did for a couple of years, and then joined the faculty in the lung cancer program. Which we've really enjoyed. My wife now works at Hopkins as well as an infectious diseases physician. So we've enjoyed our time here, and we have two small children, 5 and 7, who are Baltimore born. Going back a little bit further, I guess, so like a lot of people, I probably came into oncology partly through personal experience. My dad had colon cancer when I was just coming out of medical school, and that drove interest in the area. And there were also, I think, the other thing that drives a lot of interest from doctors going into oncology is that after many years where there were kind of minimal developments for many patients with different tumors, I think in the last 10 to 15 years, we've seen a lot of new developments across the whole spectrum of cancer diagnoses. And I think that degree of development often drives people to go into a specialty. We saw that perhaps in cardiology back in the 1970s and 80s when people started having bypasses and then having stents, and there were a lot of developments. And thankfully, I think in oncology, we've had a lot of developments in the last 10 or 15 years, which brings new and very talented people into the field to help our patients.
Patrick, it's interesting. I actually have a very similar story. When I was in medical school at the University of Chicago, at the time, I didn't really have an inkling to go into oncology, but my mom actually developed ovarian cancer when I was a second-year medical student. And to this day, I tell patients, colleagues, friends, and my wife knows this, that was the reason why I went into oncology. So I was very touched that you went into oncology too because of a loved one who had to endure. And you're right, I think our field is very special, Patrick, in that we have this brilliant science, which we'll talk about later on in this conversation, but there's also a really wonderful emotional impact. That cancer has such a stigma. It really brings a lot of emotions out in all of us as care providers, as humans. So it's really a wonderful story. And If you don't mind me asking, how would you compare the medical field in Ireland to the United States? Is it very similar? Is it different?
Um, so I think it's a little bit different in some ways and also similar. So the Irish healthcare system is something of a mixture between the dominant model in Europe, which is a government-funded public health system, and also private insurance, in that about 50% of the population in Ireland have a private health plan, and all patients, everyone is also covered by a government health plan. From that perspective, in terms of treatments and in terms of how cancer and other conditions are managed, it's not hugely different. You will find that some of the very new treatments, largely because of their expense, they're not readily available outside of the US, at least as quickly as they are in the US. So that's one of the downsides, I would say. However, perhaps one of the upsides of having a more centralized healthcare system is that things like screening and those sort of things for cancer to try and reduce incidence, they're easier to organize when you have a kind of a centralized system.
And thank you, Patrick. And Patrick, I know that you have a particular focus on lung cancer. Was there something in particular about that subdiscipline of oncology that drew you to it?
Yeah, I think so like a lot of us, Raveen, I think when I was in Ireland, I worked with somebody who was very involved in the field, kind of internationally, called Ken O'Byrne, who eventually actually moved to Australia as well. And then when I came to the US back in 2011, it was really around the time that the field of immunotherapy was taking off for cancer in general. And one of my mentors at Hopkins, who I think you know, Julie Bramer, she was instrumental in developing immunotherapy in lung cancer specifically. And I started working with her shortly after I arrived, and we've continued to work together now for over 9 years. So I think it was a mixture of kind of being exposed to people who were very committed and passionate about the field, and also the more general developments and the progress which was being made, particularly with immunotherapy around that time.
Yeah, Patrick, and I can tell the Johns Hopkins, they deserve their impeccable, outstanding reputation. Really been pioneers in immunotherapy for a variety of malignancies and with lung cancer. I was hoping, before we talk about immune therapy, which I'd like to spend most of this talk, you're an expert in the field and you've published some really groundbreaking research. I was just wondering for the public out there, we have a saying that prevention is oftentimes the best medicine. So I was wondering if you could talk to the audience about, risk factors for lung cancer, behavior patterns that one should or should not do, and also screening. I know that's a big thing with the national lung screening trial. There's not been as much uptake for that, as much as colonoscopy and mammograms perhaps, but I was wondering if you could talk to the audience about those attributes of lung cancer.
Yeah, I think Raveen, those are very important, so I think there were some risk factors we're all aware of related to lung cancer, in that about 85% of patients who develop lung cancer do have a history of smoking. It's important to note that the majority of patients diagnosed with lung cancer nowadays are not current smokers. They're people who may have smoked in the past. And you still do maintain some risk for lung cancer if you've smoked, say, 20 years ago, 10 years ago. So that's something to keep in mind. And there have been successful efforts to reduce smoking, and I think those are ongoing. But keeping in mind risk for our patients is important. The other side of it, though, is that about 15% of people who get lung cancer nowadays are non-smokers. And that's often something, unless you're in the field, you don't necessarily think about. Most patients I see who are non-smokers, they're shocked to hear that figure, and to think that there are a lot of patients out there who are non-smokers who get lung cancer, probably in the region of about 25 to 35,000 people a year who are non-smokers get lung cancer in the US. And the risk factors for that group of patients, they're not really clear. A very small proportion of them may have some familial, some family history of lung cancer, But the majority, we just haven't pinned down what exactly is driving lung cancer in those non-smokers. And there's a lot of research ongoing looking at that as well. I think in terms of assessing our risk for lung cancer, the main thing we have to date is a history of smoking, in that those patients who have a history of smoking in the past, I would recommend they and their primary care physicians consider screening for lung cancer. So as you mentioned, there was the National Lung Cancer Screening Trial here in the US, which showed a benefit in terms of picking up lung cancers at an earlier stage where they were curable. There was also a very important study published this year in the New England Journal of Medicine called the Nelson trial, which was from Europe. And that also showed that if you selected people who had a history of smoking in the past, a significant history, and there are specific figures depending on which trial you look at. But you could, if you did a low dose CT scan designed to reduce the radiation dose to the patient, if you did one at baseline and then one at 3 years and so on, you could pick up these cancers at a much earlier stage where they could be treated with surgery or radiation and reduce the risk of them progressing to a metastatic cancer, which would be more difficult to treat. So I think CT screening, as you said, unfortunately, is the uptake has been low in the United States. But I think it is something where we and others, including your group, Ravin, have been working on to try and increase awareness. And in some other countries, for example, there are huge efforts ongoing with CT screening, including having mobile CT scanners go around to different communities to try and evaluate patients and pick up these lung cancers at an earlier stage.
Yeah, Patrick, I think it's a brilliant point you bring up. One thing, when these publications came out, I was just surprised that there hasn't been more uptake in terms of screening, because if we catch these cancers early, they're much more curable, as you know better than anyone. So I hope that, as a medical community, we keep on promulgating the importance of doing these scans for patients who are at high risk of developing lung cancer. Do you think that partly it's a stigma of smoking with lung cancer? There's been some publications that some patients don't like to get screening because they think that they may have a bad habit. Do you have any comments on that in your experience?
Yeah, I think so. I think that's one element, definitely, Ravin. I think people don't necessarily want to report that they've smoked in the past, even though through no fault of their own, it's a very addictive habit, and people should be congratulated when they're able to give it up, But I think that's one element. The other element is that within the medical community, there's been some hesitancy about screening, particularly among primary care physicians, not necessarily for any bad reason, but just that they have been concerned about, for example, say you have a CT scan and it shows a nodule in the lung. So in some cases, that nodule will lead to further tests and lead to things like sampling the tumor and biopsies and that sort of thing. So it's been important to weigh up the risks and benefits of CT screening. But I think the federal groups here in the US and also internationally, where in many cases some non-US health systems are more reluctant to adopt technology. But ironically, there's a lot of enthusiasm outside of the US for CT screening in terms of reducing cancer incidence. And some studies have suggested, for example, it's more effective than breast cancer screening in detecting serious cancers, and picking them up at an earlier stage. So I think it's something we as a community and I think lots of groups are working on this. We work, for example, with a group called Longevity, who are a patient support group for lung cancer patients, and they're making a lot of efforts to publicize screening as a tool. It's always something you should discuss with your doctor or with your provider as to whether it's right for you. But I think it's something as patients they can bring it up with their physician and see whether it's a good idea or not, or whether it's indicated,
Yeah, Patrick, I agree. The patients that I've had that have a history of smoking that I've quit, we're proud of them. It's a very, very difficult habit to quit. And I think it's wonderful that we have screening now available for lung cancer. And it's interesting with screening, it seems like it's an opportunity to counsel them about smoking cessation, whether it's behavior techniques or medication. So I think that's fantastic. Before we talk about immune therapy, just to piggyback on what Dr. Forde said, and it was a brilliant point, is that there is a subset of lung cancers that are really not due to a smoking history. And there's some data maybe with radon exposure, but there are some mutations, what we call actionable mutations. And I want to get Dr. Forde's opinion on this, but one book that really touched me, there was a Stanford neurosurgeon, Dr. Kalanithi, and he wrote a very beautiful book called When Breath Becomes Air. And he was really a brilliant neurosurgeon at Stanford. He was not feeling himself. He was a lifelong never smoker. And in his 30s, he was diagnosed with stage 4 lung cancer with no smoking history. And when they did a biopsy of his tumor, he had something called an EGFR mutation, epidermal growth factor receptor mutation. And I was hoping if Dr. Forde, if you could kind of talk about that part of lung cancer, treatments before we delve into the immunotherapeutics that we have available.
Yes, Raveen. Yes, I've read that book as well. It's an excellent book, very emotional and kind of extraordinarily well written. In terms of so lung cancer as a disease has really changed a lot, as I've said earlier, over the last maybe 10 or 15 years. Apart from the fact that, say, 15 years ago, our standard treatment was chemotherapy for almost everybody who had lung cancer, which had spread outside the lung. Nowadays, there are three kind of main types of treatment, one of which is chemotherapy which still has an important role. The second one is immunotherapy, which we'll talk about in a little while. And the third type of treatment is treatment directed at specific mutations or gene changes in the tumor. And probably the most common of those ones is the one you just mentioned, EGFR, which is present in about 15% of patients' tumors. The majority of those patients are those who are non-smokers or have a very light smoking history. And thankfully, over the last 10 years or so, there have been multiple drugs or new treatments developed for EGFR lung cancer, and also for a number of other lung cancers which can have gene changes in them. The ones we most commonly hear about, there's one called ALK, or ALK, it's called. Another one called RET, R-E-T, ROS1, ROS1. And these mutations are present in a very small percentage of all patients with lung cancer. Apart from EGFR, the other ones are present probably in 1 or 2% of all patients with lung cancer each. However, patients who are non-smokers who get lung cancer are more likely to have one of these mutations in the tumor. And indeed, for all patients who have a subtype of lung cancer called a non-squamous lung cancer, it's recommended to test for these mutations, ideally using a panel which would test for all of them. And that's an important point in that the FDA has approved a number of these testing panels to look for these mutations. And the guidelines for the treatment of lung cancer, what we call the NCCN guidelines, they also recommend testing for these mutations where there's an FDA-approved treatment. So that's specifically for patients who have non-squamous lung cancer, and particularly a type called adenocarcinoma, and that makes up probably about 50 to 60%, maybe a little bit more, of all patients with metastatic lung cancer.
And so, Patrick, thank you. So Dr. Kalanithi, he tragically died at age 37. He was put on different targeted drugs that targeted this EGFR mutation. I did want to share one quote because this quote, when I read it, it really touched my soul. It was one of the best quotes I've ever read. But basically, him and his wife were deciding whether or not to have a child because he was going through this very difficult diagnosis, and they did have a beautiful child. And when he was dying, he wrote this quote. He wrote this about his daughter. When you come to one of the many moments in life when you must give an account of yourself, provide a ledger of what you have been and done and meant to the world. Do not, I pray, discount that you build a dying man's days with a sated joy, a joy unknown to me in all my prior years, a joy that does not hunger for more and more, but rests, satisfied. And this time right now, that is an enormous thing. And this is a dying man's wishes. And I think to me, this quote really balances the beauty of oncology and that we really are privy to patients' hopes and dreams and fears, along with balancing that with providing scientific driven data to help treat them, from their cancer. And I think the field of oncology, Patrick, I know you would agree, really is unique in that way, don't you think?
Yes, no, I agree, Raveen. That's a very a profound quote. I think it's something which comes up again and again for patients who are diagnosed with the cancer, and so, as you said, it's important to balance these new developments along with the traditional physician or provider-patient relationship, and providing emotional and psychological support at what's a very tough time, no matter what type of cancer you have or how it's been diagnosed, and especially at the moment when everyone is stressed out from this pandemic which is going on. I think it's an even more difficult time, and even more support is needed.
Yeah, Patrick, it's been one of the wonderful things about being an oncologist, which I know we're all grateful for. Every oncologist I talk to, everyone's grateful for that. So thank you. So Patrick, I know from 2007 to 2010, I had the good fortune to do my hematology and oncology fellowship at MD Anderson Cancer Center in Houston. And I remember for lung cancer at the time, the treatments really revolved around surgery if it was localized, if the tumor was localized, oftentimes chemotherapy plus or minus radiation. And I was hoping if you could tell us about the variety of treatments for localized and metastatic disease from 2007 to now. So I really want to kind of discuss, the era of what things were like back then and where they're going right now.
Sure. Yeah. So Raveen, going back even a couple of years before that, there was a famous study which was published in the New England Journal of Medicine, where 3 different types of chemotherapy had been compared for the treatment of patients newly diagnosed with metastatic lung cancer. And unfortunately, it was an important study, but it didn't show any real difference in outcome for those patients from those 3 different types of chemotherapy. Then I think one of the big developments which we spoke about a few minutes ago, was this development of a treatment for EGFR lung cancer, which was a pill treatment called erlotinib, and there were a couple of other similar medicines developed around the time. And the important development there was that people went back. Initially, all lung cancer patients were being treated with erlotinib, and then scientists in the lab went back and looked, and they were able to. We knew from looking at those patients, some patients did extremely well, where the tumor after a few weeks would have shrunk and the patient would be feeling much better, but didn't apply to all patients. And initially, clinical things like non-smokers seemed to do better. Patients who were from Asia or female did better. But looking in more depth, people were able to find out that those tumors who responded the best and had dramatic responses had EGFR mutations. And that was kind of recapitulated then in multiple other targeted therapies over the subsequent years. I think about 2011, there was the discovery of the ALK gene therapies, targeted therapies. A medicine called crizotinib was approved by the FDA, and that was about 1 or 2% of patients. But again, a pill treatment which led to dramatic responses for those patients and improvement in their symptoms. And subsequently, other new drugs for both EGFR and ALK have been approved. And over the subsequent 7 or 8 years, we've seen multiple other genes, some of the ones I mentioned, ROS1, RET, and even newer ones which are kind of in clinical trials but not approved, all leading to good responses. At the same time, chemotherapy was being used and still being recommended for patients, and it still is very effective for some patients. However, back in 2008, 2009, my colleague at Hopkins, Dr. Bramer, led a trial here looking at this new type of treatment called an immune checkpoint inhibitor, or an immunotherapy drug, which is given intravenously either once every 2 weeks or 3 weeks or even 6 weeks now. They've spaced out the time period. And so because Dr. Bramer specialized in lung cancer, she pushed to have some lung cancer patients included in that initial clinical trial. Traditionally, immunotherapy was taught to work best for certain cancers, melanoma in particular, and kidney cancer. And the third cohort included in that trial was lung cancer. And as expected, or as hoped for, the melanoma patients did well with the medicine, much better than had been seen in previous immunotherapy clinical trials. The kidney cancer patients also did well. However, several of the lung cancer patients had some tumor shrinkage, which was not expected. And Julie and others here pushed to expand that cohort of patients. And indeed, in subsequent trials, these immunotherapy medicines were shown to be particularly effective for some patients with lung cancer. And over the subsequent years, it was then shown that when you combine some of these immunotherapy medicines, and these are medicines, to give some names, for example, a drug called nivolumab, the trade name is Opdivo, another one called pembrolizumab, which is Keytruda, and then the third and fourth drugs which are approved for lung cancer are atezolizumab, which is Tecentriq, and durvalumab, which is Imfinzi. So those are now, 10 years later, we have 4 drugs which are approved targeting PD-1 or PD-L1, its ligand, for lung cancer. And essentially almost all patients are considered for these medicines who have stage 3 or stage 4 lung cancer. And some of the medicines work particularly well in conjunction with chemotherapy, for example. So Keytruda is given in conjunction with chemotherapy for many patients who are newly diagnosed with lung cancer, which is spread outside the lung. It can also be given on its own for some patients where there's a marker on the tumor called PD-L1, and if that's present at a high level, sometimes Keytruda on its own can be effective. And indeed, other combinations are also approved. So it's become a very complicated field kind of in the space of 10 years, but that's very welcome as well because we have new options for many of these patients.
Patrick, thank you. I remember when I first started hearing about immune checkpoint inhibitors for lung cancer, I got chills. It just seemed like science fiction was coming to the clinical arena to really help our patients out. And Patrick, when patients ask me about immune therapy, there's commercials on TV now. Former President Jimmy Carter for melanoma got it. So there's a lot of lay press with these drugs. The way that I've described it now, and I wanted to get your thoughts on this, is we have various immune type of cells in our body, one of which is a T-cell lymphocyte. And there was a variety of really brilliant scientists, 2 of which won a Nobel Prize, Dr. Hanjo from Japan and Dr. Allison here in the United States. And basically, I tell patients that on the T-cell lymphocytes, there's breaks, more than one break, and one's called PD-1 and one's called CTLA-4. So immune therapeutics essentially take away the break from the T-cell lymphocyte, reinvigorating your own immune system to fight the cancer for you, almost waking it up from its slumber so it can fight the cancer. And I was wondering if you could talk a little bit more about the science of checkpoint inhibitors and how it works and why some patients may respond to it better than other patients.
Yeah, I think that's a very good description there, Raveen. I think the two broad classes, as you said, are the medicines that target the PD-1 or PD-L1 receptor, and the other class are the CTLA-4 inhibitors. And what you find really is that there are kind of broad categories of patients or tumors which may be more likely to benefit. One particular marker we look at in patients who are newly diagnosed with lung cancer is this marker called PD-L1, which is present on the surface of lung cancer cells. And so this is a relatively straightforward test in that the person, when the tumor sample is taken, the tumor is sliced up into sections and put under a microscope and stained with this PD-L1 marker. And depending on the presence of that marker, it's given a percent score. So say from 0, where the doctor can't see any PD-L1 expression on the cells, up to 100%, where every cell is expressing this PD-L1 marker under the microscope. And that can help guide us as to whether these medicines are likely to be beneficial as the first treatment for lung cancer. So that's one of the very important and also relatively straightforward tests we do when a patient comes in with metastatic lung cancer. And that test is usually all going well. If the sample is adequate, it should be back within a few days. And if that marker is high, and the cutoff used is 50% or greater, then this medicine Keytruda can be an option. And so in that setting, Keytruda on its own can work for probably 50% or more of patients in terms of causing significant shrinkage of the tumor. And when that shrinkage happens, it tends to last for quite some time, usually more than a year in that situation. The advantage of Keytruda and these medicines is that on average, when they're given on their own, they tend to have fewer side effects than chemotherapy. However, on the same point of view, the side effects are very, very different. And they're generally related to what you said in terms of revving up the immune system. So in addition to the immune cells attacking the tumor, occasionally they can affect our own body. And as oncologists, we're vigilant for those type of side effects when patients describe, say, for example, a skin rash or sometimes loose stools or diarrhea. Those sort of symptoms can sometimes be related to immunotherapy. But one of the advantages, I think, on average, is that at least as a single medicine, these PD-1 or PD-L1 inhibitors are generally well tolerated by most people. And that's been a welcome advance as well, I think.
Patrick, I think it's been an enormous advance. And as a clinician, to be able to offer patients these drugs has meant the world to us. As oncologists, it's provided so much hope. Patients are living longer. Patrick, so one thing that comes up a lot from our patients here in Annapolis and other places I had the good fortune to train at is when I was in my training, well over 10 years now, for stage 4 lung cancer, all comers, I remember that with just chemotherapy alone, we used to quote a 5-year survival of under 5%, maybe much under that, which was very daunting and sad to quote a patient. The average prognosis, some patients do better, of course. No, I was really struck when I read an article a couple years back, I guess, where on immune therapy now for stage 4 metastatic lung cancer, that about 20% of patients are alive and well at 5 years. Mm-hmm. And so the question comes up is, are we curing stage 4 metastatic lung cancer with immune therapy?
Yeah, I think it's a very good point, Raveen. I think so it has changed, and it's a question that would be very natural for anyone to think about if they were diagnosed with the cancer, I think the short answer, I think, is that some patients with metastatic lung cancer are being cured. It's probably still a small number of patients, and we have, because of the experience of everyone over many years, we've been hesitant to use that word, but I will say kind of in the 9 or 10 years here at Hopkins, I have a number of patients who are still in remission from their metastatic lung cancer, and it's been 7, 8, 9, 10 years. And that, so most of those cases are related to immunotherapy. However, I think it's important when a patient is newly diagnosed with lung cancer, I often say, we don't necessarily have enough information about the tumor when someone comes in the door the first time to be able to even talk about prognosis, because prognosis varies a lot depending on the gene mutation in the tumor as well. In that some of these pill treatments for these specific gene mutations, patients live 5, 7, 9 years or longer. And so in some cases, we're not getting to the median or the average lifespan for some of these clinical trials, which is a huge advance as well. But I think one of the big things we do see with immunotherapy is that if the tumor responds well to it, it tends to be a very durable response in most cases. And that's really welcome, you know. And one of the questions that comes up for us sometimes is, if you get to 2 years on the treatment or 3 years on the treatment, can you stop it? And that's an ongoing question. We don't have a really clear answer on that. How long do you have to be on the immunotherapy for? Because we see patients, for example, where the tumor has responded really, really well, has shrunk down, has stayed in remission for a long period of time. And can we stop it at some point? I think we probably can for some patients, particularly if they're having side effects from the medicine. But it's a question people are still trying to answer in clinical trials as well.
So Patrick, when you hear a patient with metastatic lung cancer living 5 to 10 years, it gives you chills. And it's really just amazing. It's a watershed moment in our field. Patrick, just to go back, you know, we talked about earlier, there's about 15% of patients or so in the United States with stage 4 metastatic lung cancer who have these actionable mutations, EGFR mutation, ALK, ROS1 rearrangement. And thank you for going over those. And oftentimes those patients are non-smokers or never smokers. So one thing that struck me a couple years ago when I was reading some articles and discussing it with wonderful colleagues like yourself and my colleagues here in Annapolis is that oftentimes the patients who don't have a robust or any smoking history actually do not have that good of a response to immune therapy. And then many were positing that perhaps when, let's say, a person smokes, that leads to more mutations in the tumor because of all the carcinogens of the smoke, and that the immune cells, your own immune cells, are better able to recognize the cancer because it has more mutations. The cancer is more abnormal than your normal cells. So I just was wondering, in addition to that predictive marker, PD-1 or PD-L1 that you talked about, do you have any thoughts about immune therapy for patients who don't have a robust smoking history?
Yeah, I think that's a good point, Raveen. You know, there's I think the point you make about the tumor mutation burden, which is the term we use for the number of mutations present in the tumor which are not present in the patient's normal cells. I think that's a potentially a helpful marker for some patients, probably not as important as the PD-L1 marker I spoke about, but still it can be helpful. And we find, as you said, patients who are non-smokers, and particularly those patients who have certain of these gene mutations, they're less likely to have a high tumor mutation burden and less likely to respond to the PD-1 medicines on their own, the immunotherapy drugs. Now, having said that, there are some very limited data from other clinical trials suggesting that perhaps combining chemotherapy with the drug called bevacizumab, which blocks the blood supply to tumors, and perhaps with an immunotherapy drug as well, can be effective. Now, and that it may be relevant for patients who are non-smokers and those who don't have an EGFR mutation, because the FDA approval actually excluded patients who had EGFR. But for other non-smokers who have those who don't have an EGFR mutation but are non-smokers, that might be a good option for those patients. There are also lots of clinical trials ongoing for specific groups of patients like EGFR and ALK and ROS1, trying to add additional immunotherapy drugs to the approved agents like Opdivo or Keytruda, such as adding a vaccine, for example, to stimulate the patient's immune system further, or to inflame the tumor. It's because what they often find when you look at these non-smoking lung cancers, they often have very few immune cells of the patient's immune system, immune cells in the tumor to start with. So one idea is, if you give a vaccine, can you actually inflame the tumor and bring in some of those immune cells in addition to giving the approved immune medicine? But I think it's a very important area of study, because obviously you'd like to be able to bring immunotherapy to be effective for as many patients as possible. The other thing I would say, just as a side note, is that while most of these mutations are present in non-smokers, there are definitely some patients who have a smoking history can have these mutations. So for patients who have non-squamous lung cancer, which is the more common type, it's recommended to test everyone for these mutations irrespective of their smoking history. And indeed, there are some clinical trials for one of the commoner mutations in smokers called KRAS, showing some early benefit from these targeted therapies for KRAS. So I think that might be the next story we see for lung cancer patients, that even some of the mutations which are present in smokers may be amenable to treatment as well with targeted therapies.
Yeah, Patrick, I think that the KRAS, I think codon, was it 12C?
Yes, exactly.
Yeah, that's very exciting. The more treatments we have for patients, the better. Patrick, one of the interesting things for our group joining Maryland Oncology Hematology, and you had talked about it, was clinical trials. And, our organization has lots of clinical trials. And it's very important, for us to have patients participate so we can keep on advancing the field, provide more options. So I was hoping if you could tell the audience about from your perspective, being a brilliant clinical investigator, translational scientist, the importance of clinical trials. I know at Maryland Oncology Hematology, we place a great emphasis on it. Clearly, they do that at Johns Hopkins. If you could tell the audience the importance of trials to really advance the field of oncology, and in particular lung cancer.
Yeah, I think, Raveen, it's never been kind of clearer than in the last 5 to 10 years, in that many of the earliest of those patients I mentioned who are alive at 7 and 10 years, they were enrolled in some of the clinical trials of these new drugs at Hopkins and other centers over the past 7 or 10 years. Historically, the enrollment in clinical trials has not been brilliant in the US. Probably about 5 to 7% of people across all cancer types enroll in clinical trials. However, if you look back at those patients, they tend actually to do better. So on average, a patient who enrolls in a clinical trial usually will have a better outcome. So if you aggregate the data, the advantages, I think, of clinical trials are potentially having access to new treatments at an earlier stage in some cases. What we've seen, particularly with immunotherapy, is that sometimes the clinical trial option can have less toxicity than the standard option might be, which, for example, might be an approved chemotherapy drug for patients whose cancer has grown despite previous treatment. And the other advantage, I think, is giving back or giving to other patients with cancer and to society at large. Patients who take part in clinical trials, that they're contributing to developing new treatments for cancer, which will help people in the future and may help themselves as well, but will help other patients and help other people in the future who are confronted with cancer. That. And we and others, I think we've had a very good relationship over the years, Raveen, with patients going back and forth who have been on trials with you or over here at Hopkins, and they've had their treatment in Annapolis or in Baltimore. So I think it's having relationships between different centers as well is important in terms of trying to find the best place for each particular patient to have their treatment,
Yeah, Patrick, I agree. The more every year that passes, and as an oncologist, I realize the importance of teamwork and really creating a strong team around every patient to look at every potential option. And I also think you hit the nail on the head. when patients ask me about trials, I tell them that drugs like Keytruda and Opdivo 10 years ago were on trial, and we saw spectacular results, and that got these drugs approved, and we have to kind of keep on moving forward. So Patrick, if I could, do you see the field for stage 4 lung cancer going where we're giving combination immune therapies? Let's say we're taking the break PD-1 off, and we're taking the break CTLA-4 off, or maybe another break, of the immune system. Do you see the field to advance it going where we're looking at combination immune therapies to really help patients out?
Yeah, I think so. There's some very promising areas as well. I think so. We have seen one combination immunotherapy be approved for lung cancer, which is the two targets you mentioned earlier, Raveen, CTLA-4 and PD-1. So that's two medicines called nivolumab and ipilimumab, and that's one of a number of treatments approved for patients with newly diagnosed metastatic lung cancer. It may have benefits for some patients, but not for all, that particular combination. However, there are also a lot of clinical trials ongoing looking at combining PD-1 medicines with new immunotherapy medicines targeting other targets in the immune system, or even with some drugs that target other things like DNA repair. How the tumor repairs its genes, for example, is one thing. Or pill treatments in some cases, which reduce or increase the level of immune activation in the tumor. So I think if you look around at the moment, there are probably well over 1,000 clinical trials active in the US looking at combination immunotherapy treatments across tumor types. And no matter what state you live in, there's probably going to be some form of a clinical trial which may be suitable for you as a patient. The other big development we've seen in the recent past is that immunotherapy has been approved for the treatment of stage 3 lung cancer, which is lung cancer which is in the lung and has usually spread to some of the lymph nodes in the middle of the chest, and is not amenable to surgery, but is amenable to treatment with chemo and radiation. And a drug called durvalumab was approved for patients after chemoradiation, which is an immunotherapy medicine. And we saw in that study that durvalumab improves survival by anything from 25 to 40%, depending on the figures you look at. And that survival is very prolonged. So when you look at 5 years, there's a significant improvement in survival for those patients. So those are the developments in stage 3 lung cancer. And then in very earlier stage lung cancer, which is amenable to surgery, we and others have been looking at giving immunotherapy prior to surgery. And there have been completed trials, and we're waiting for the results of those clinical trials to see if that will be an effective strategy as well.
Yeah, Patrick, being a general oncologist, we give a lot of immune therapy drugs here in Annapolis. And one thing I've been struck by is oftentimes for immune therapy, we'll study it in a stage 4 setting, which is the most advanced, but we're trying to purpose the drugs earlier. Maybe we can kill the microscopic cancer cells that we can't see earlier so they don't spread. I believe the trial you talked about was a Pacific study for stage non-resectable lung cancer after chemoradiation, within 42 days after chemoradiation is over, giving durvalumab for a year. And we here in the community setting think that was spectacular. It's really helped our patients out tremendously, Patrick. And that's a nice segue. So in 2018, Dr. Forde was the first author of an article that appeared in the New England Journal of Medicine. And just for the audience, that is our holy grail journal in the field of medicine, let alone oncology. And when I saw Patrick's name there, I was very proud of him. I knew Patrick when he was a fellow. Was it 9 or 10 years ago now, Patrick, were you a fellow?
Yeah, going on 8 years ago now, but we're lucky enough to get that publication. That was actually a study that people mainly conducted at Hopkins. So patients came and enrolled in the study, and they received immunotherapy prior to surgery for their lung cancer. And we saw very promising results and did a lot of analysis in the lab, looking at specimens and samples from patients who enrolled in that trial, suggesting that perhaps, as you said, these drugs are effective for metastatic lung cancer. Can they prevent relapse of cancer at earlier stages? That study has led to other studies in lung cancer, so what we call phase 3 trials, which are trying to evaluate the kind of longer term effectiveness of the treatment. And there was recently some data released suggesting that one of those phase 3 trials at least shows that the rate of the tumor, so when you receive these immunotherapy drugs prior to surgery for lung cancer, the rate of the tumor disappearing, or there being no residual viable tumor in the resected sample at surgery, is higher if you receive these drugs with chemotherapy compared to chemo alone. And now we're going on to wait for the longer term results of that study, and there are several other studies exploring that as well. So I think it's a very exciting area. As you say, Raveen, these immunotherapy drugs have the potential to lead to long-term remissions for a small group of patients with metastatic lung cancer. And the hope would be if you can integrate them into earlier stage lung cancer treatment, they can benefit even more patients.
Well, Patrick, when we presented your article at our tumor board in 2018, you were a celebrity. We were so excited. And, for the audience, one of the things we were very struck by with Dr. Forde and colleagues' publication is, so they gave this immune therapy before surgery. So when the surgeons took out the tumor, they were able to study the makeup of the tumor. And many of the tumors were actually killed, weren't they, Patrick, just with the immune therapy alone. And when they did the surgery, they saw that the tumor was a necrotic dead mass. And I just thought that was just amazing, because you could see with the actual pathology specimen that the immune therapy worked so well. It was almost like a quote unquote an in vivo type of response. It was remarkable.
No, I think it did lead to kind of unexpected results in some ways, but it did, and you could actually see the T cells infiltrating into the tumor when you looked at the specimen. We were able to mark the tumor with particular markers for T cells, which showed that they were being heavily infiltrated, and many of those patients are still coming back to my clinic. One of them, of the patients who enrolled in that study, he's become a bit of a celebrity with us, in that he set off on a motorcycle ride from Delaware down to the southern tip of Argentina shortly after being on the trial. So he was sending us updates, and he set up a website. So he's an entertaining character. He's still in touch with us. Last I heard, he was in Alaska. So.
Oh my God, I'm jealous. He's a world traveler now, Patrick. He's a funny individual, but so it's always these sort of good stories are encouraging, and I think we and others have a lot of trials in this area, and as well as for metastatic lung cancer. So I think for all stages of lung cancer now, there are a lot of new developments coming along. Great news. It's very exciting, and for the audience, one thing as medical oncologists, whatever cancer we deal with, I remember when my mom was first diagnosed with ovarian cancer and she had surgery, and at the time in the year 2000, she had chemotherapy afterwards. And I remember my mom and dad asking, why are they giving me chemotherapy? And, oftentimes there are cancer cells that are microscopic that can still be in the body despite surgery or radiation. And those are the tumor cells that you can't see on a scan, whether it be a CAT scan or PET scan, but those cells can metastasize and spread. So when we give medications like chemotherapy or immune therapy, we endeavor to try to kill those microscopic cells early in their infancy, if you will, so they don't metastasize and spread. So Dr. Forde's article was really incredible. Now, Patrick, I know they have a slew of clinical trials underway, and I think one is called Alchemist. There's a lot of variety of clinical trials out there. Do you see in the future, I know for stage 4 and stage 3, immune therapy has put its stamp for lung cancer, no question. But do you see in the future for stage 1 and stage 2 lung cancer that whether before or after surgery, that may replace chemotherapy let's say for stage 2 lung cancer, that will give immune therapy after the surgery as opposed to chemotherapy?
Well, I think it's a good point, Ravina. I think so most of the trials at the moment, ironically, when we started developing immunotherapy, many of us thought we'd be able to eliminate chemo, but in many cases, immunotherapy actually seems to work pretty well when combined with chemotherapy or given around the same time. So most of the clinical trials are still involving chemotherapy, at least as an option. So the trials where they're looking at giving immunotherapy prior to surgery, it's given in combination with chemo. And in the trials which have been completed and we're waiting for results, the one you mentioned, for example, the Alchemist trial, that trial, patients are still offered chemotherapy after surgery. They may or may not decide to have chemotherapy, and then they get a year of the immunotherapy medicine. One thing I didn't mention, which was a big development this year, or has the potential to be a big development, was that for those patients who have these EGFR mutations in the tumor, there was a trial called the ADORA study, which was published recently, which showed that for that 15% or so of patients with adenocarcinoma who have EGFR mutations, taking a drug targeted at EGFR called osimertinib or Tagrisso significantly reduced the likelihood of the cancer returning after surgery. Now, that study is still ongoing in terms of follow-up, and I don't believe the FDA have yet approved that treatment, but I suspect in the near future we'll be looking at that for earlier stage lung cancer as well. So in addition to immunotherapy potentially being an option in the future for earlier stage lung cancer, I think potentially some of these targeted drugs, I know there are studies ongoing, for example, for the ALK gene fusion as well in earlier stage lung cancer and for ROS1.
I remember reading about the ADORA study, very exciting. Is it fair to say that for the EGFR mutation, exon 21 and exon 19 are the main mutations that we target?
Yeah, exactly. And that's, again, it's so if you look at all comers with lung adenocarcinoma in the US, it's probably about 13 to 15% of all comers have that particular mutation. And it's the exon 19 and 21, as you said, Ravine. There are rarer mutations present in EGFR, but they don't tend to be as sensitive to the targeted drugs. Most of the testing, though, nowadays looks for all of those mutations in EGFR, so you'd find out either way which one it is.
So, Patrick, I wanted to thank you for your time. This was a great discussion. I also wanted to thank you for being a wonderful friend and colleague over the years for all of us. I know we've shared many patients with you, and our patients have loved your skill set, which is prodigious, but also your kindness, which are great qualities for an oncologist. And for us, please check us out at marylandoncology.com. We have a great oncology program here, and we partner with a lot of institutions like Johns Hopkins. So we'd like to thank Dr. Forde for your time, and thank you for the audience for listening.
Thanks very much, Ravine, and thank you to everyone for listening. Take care.
Hi, Patrick.
Bye-bye.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/Oncology Radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.